So tonight's going to be a relatively short class as well. So there's a lot of slides. It's not really, I say it's a lot of slides. It's more like 60 something. There's a lot more slides than what's necessary, but it is what it is. We'll get through this just fine and then be done with it. Give me just a second though. One of these, there we go. All right. So like I said, tonight's going to be a pretty easy night. What we're going over is actually CPR. But we're going to do it with a little bit extra information. If you guys have ever been certified in CPR, about 90% of this is going to be just trying not to fall asleep. We're going over the rate, the depth of the chest. We're going to talk about adults, child, and infant. We're going to talk about the normal, all the numbers, everything that you've done when you did that death by DVD for 3 hours. And that's pretty much it. Tonight is going to be all of the academic portions of it. The hands-on stuff we'll be doing at the boot camp, and that will complete your BLS research. So those of you that need it, if you need it before the boot camp, I understand that kind of sucks because then you have to pay extra, obviously, for whoever you go to. But if you are able to wait for the January boot camp to get your research, then I wouldn't worry about trying to research with anybody else, or even us for that matter, because it would just be a waste of money. You're going to get it through the course of this class. We will be talking about this in a little bit more, a little bit higher of a level of training, because that's what you are, right? You're not the Walmart worker that just needs to know how to pump on the chest. You're going to be dealing with monitors. You're going to be dealing with helping paramedics while they're getting ready to give meds and stuff like that. So we're going to talk about some things that the direct hands-on portion might be a little out of your scope, but knowing about it, having that knowledge, especially if the guy sitting next to you happens to wear a gold patch and he needs your help with something, then this will make you useful to him. We're going to go over a couple of things about why we do what we do, why we put the pads where we put the pads, why do we do 30 compressions at a time, these kind of things, and what are the shockable rhythms. Even though as an EMT you can only really shock with an AED, which means you're not going to interpret a rhythm, you still want to have that basic knowledge of what's a shockable rhythm, what's not a shockable rhythm. Because when you get on a truck, you may be using the monitor to deliver an automatic shock. That's just what it is. Most ambulances don't carry a monitor and an AED. You guys in the fire service, y'all are typically going to use a regular AED. Those of you that go to a hospital, it's kind of a crapshoot of wherever you're at in the hospital. But like I said, I'm going to try to teach you guys to the next level and not just a CPR certification. Otherwise, I'd have just sent you the heart code software from the AHA tonight and we wouldn't have even had a class. So, without further ado, let's get going. Okay. So the principles of BLS were introduced in the 1960s. And prior to this, it was pretty much, this is back when, if you think about when we talked about the ambulance service in chapter 1, they picked you up in a hearse. That way, if you died before you got to the hospital, they just detoured and took you to the funeral home instead. Since then, specific techniques have been reviewed and revised every 5 to 6 years. Right now, we're still operating on the 2015 standards, but this month, actually, I think the 21st, we're going to switch to the 2020 standards. So that being said, when you come to boot camp, I may tell you some things that are different than what I'm going to tell you tonight. What you're learning tonight is 2015 standards. I don't know what's in the 2020 yet. We're still working on figuring that out. But it won't be much different. I don't see it being much more of an overhaul. It'll be something. In fact, it'll probably be something that we're already teaching you just because we know it's on the way. The most recent review was conducted by the International Liaison Committee on Resuscitation, or the ILCOR. So here's something interesting about BLS. Whether you get American Heart Association's BLS or Red Cross is BLS, or any other agency's BLS if they're accredited through, or if they ever say that they're on the same level as AHA or something like that, then what that means is they're teaching a curriculum that was discussed and looked at and agreed on by this organization. AHA does not make the rules per se. They're not even really the main research organization. ILCOR is. They're the ones that do all the research, all the papers. They're the ones that say, survival rates, if you do this, this, and this, have been better. And then the AHA, the Red Cross, all these different organizations will take that knowledge and create their curriculums with it. So if you were to take Red Cross or AHA, if you're a Red Cross certified CPR provider and you're standing next to an AHA certified CPR provider, you've got the same knowledge. The everything they taught you was the same, and that's why. It's because it's not their curriculum. They're just using what the ILCOR had put out. Now that being said, AHA is on the committee for the ILCOR, but they're not the ones that actually created all this stuff. So there's a couple different elements to BLS. BLS, as you guys know, is basic life support, right? This is pretty much anything that's non-invasive. Once you break the skin, either with a shot or an IV or an advanced airway, then you're no longer in the BLS territory. But CPR, and really you guys as EMTs, this is your wheelhouse. So these are the things that you handle, and you don't necessarily need a paramedic for these things. Um, Airway obstructions. So if you do abdominal thrust, respiratory arrest, you can bag a patient with a BVM, and then cardiac arrest, you can give CPR. Now there are ALS interventions. I'm not saying don't call a paramedic if you're dealing with this stuff, especially the cardiac arrest, but you don't need a paramedic to do CPR, and that's what we're basically going to be talking about tonight. If the patient is in cardiac arrest, then we're going to change a little bit of how we go about doing our ABCs. We're still going to focus on them just like we do any other patient. But if you show up, you do your scene size up, you get to your patient, and first thing we do before ALS or ABC rather, is we check their level of consciousness. So that AVPU, you're going to do that, and it's either alert, verbal, painful stimulus, or unresponsive altogether. So the minute you get to your patient, once you've made it through your BSI scene safety, do I need additional resources and all of those steps, the very first thing you do when you get to any patient is you determine their level of consciousness. If they're alert and talking to you, fantastic. Those are typically the easy calls. If they're drowsy, not really talking to you, but if you shout at them and they kind of grunt or groan, or even if they're just alert to or responsive to pain, where they don't do anything when you shout at them, but when you give a sternum rub or you pinch their shoulders, and they grunt or grimace, that's a response. That's a good thing. That means they're still alive. But if they're completely unresponsive, then pause your assessment right there and just check a pulse to see if they are still alive. All right. I mean, what's the point in going through your assessment if you're working on the dead guy? So you get up to them, they're unresponsive, check a pulse. Anytime I tell you to do something in this chapter, and it's a pretty good thing to say for pretty much any of them, is if you're going to do something like checking a pulse, stopping compressions to give a breath or whatever, if you're ever asked how long do we do something, it's no more than 10 seconds. All right. So for no more than 10 seconds, we're going to check a pulse. And can anybody tell me where we're going to check a pulse if a person is unresponsive? People with me? Okay. So this response came privately. It's correct. So Tamara, you got the right answer. You were the first one to pop it up. I don't know if you know, you're just talking to me specifically. The pulse that we want to focus on in this case is the carotid. You're correct, Eileen. You're also right. It's in the neck, but using the right term for the right artery and everything, it's the carotid artery. Which one? There's two of them, all right? There's one on the left side, one on the right side. Which one are we going to feel? Any guesses on that one? Do we feel the left one or the right one? Okay, so I got to vote for the right. Anybody say the left? Got to vote for the left. So you're both right. What determines it? It's a safety reason. So if you guys don't know, it's all right. The closest to you, yes, good job. The side closest to you. We don't want to reach across our patient. If he's unconscious and you're still at the point of checking the pulse, let's say he's got one and he's down because he had a hypoglycemic emergency and he's not going to be in his right mind. He starts to come to, and you're reaching over him. He might think that you're attacking him, and he can come up swinging. Um, there's also, you know, drunks do exist. We try not to assume anybody's drunk right out the gate, but I mean that is a thing. So always check the pulse and do everything you can on your side of the patient. Don't reach across, don't step across, don't do anything over the patient except compressions. There's no other way to do that. Um, this way, if they do come up, you're not leaning over them with your center of gravity straight up. You're kind of already hanging off to the side. So all you got to do is just back the rest of the way up, and you're pretty safe. So we check a pulse, no more than 10 seconds. And now we either find out that they do or they don't have one. If they do have one, then we continue our assessment like we normally do. You're going to go airway, breathing, circulation, and just keep on going. If they don't have one, then they're effectively dead at that point and they're in cardiac arrest. We need to do CPR. All right, that's one of the points in your assessments where you're going to make a decision on how you proceed. So depending on what you see, you may not do it exactly like it's written on those assessment sheets. If they don't have a pulse, we're going to go into CPR. CPR guidelines say that we start with circulation. So you're going to skip the airways, skip the breathing, put your hands on their chest, and actually start doing compressions. Only seconds should pass between the time you recognize that a patient needs BLS and the start of treatment. There's a couple of things about that I've seen where they've said studies of like brain damage and things. I don't want you to have to really memorize that, but here it is in the slide. Permanent brain damage is possible if the brain is without oxygen for up from 4 to 6 minutes. The reason that we go, can somebody tell me why we do compressions first? Because we used to not do it. It used to be airway, breathing, circulation, regardless. But for cardiac arrest, they put compressions first now. Anybody know why they did that? Okay. So oxygen to brain is that's why we used to do airway and breathing first. We assumed that we needed to put the air into the bloodstream and then circulate it, right? But we come to find out, um, patients usually have they have oxygen in their bloodstream ready to go when the heart stops. So what we're doing is that first round of compressions, we're actually circulating the oxygenated blood that they already have. So we're going to go CAB and get that going. Can y'all still hear me? Okay. So time is critical. Here's something, I think they put this in the DVDs, or I'm sorry, I think it's in ACLS, but it's still the same. In the first minute, you have like cardiac irritability, and that can be anything from like VFib to VTAC, something that would possibly be shockable. But it's only that's how cardiac arrest starts. Usually, your electrical issues are where it begins, and then it goes into straight up cardiac arrest from there. 0 to 4 minutes. If you can get somebody back, get them what we call ROSC, which is return of spontaneous circulation, then they have a really good chance of making 100% recovery, or at least pretty close to it. So brain damage is not likely. After 4 minutes, if you haven't at least started CPR, brain damage is possible, and then 6 to 10 minutes, it's very likely. More than that, even if you get them back, they're probably going to be a vegetable. All right, so let's talk about CPR. CPR establishes circulation and artificial ventilation in a patient who is not doing it on their own. So for everything that we do with CPR, we're essentially trying to trick the body into thinking that it's business as usual, right? If they don't have a pulse, we're going to pump on the chest. If they are not breathing, we're going to be breathing for them. That's what determines it. So that being said, if you ever see a patient, be it in an evaluation or the real world, if I tell you that they are not breathing, but they do have a pulse, don't let that trip you up. All that means is you're going to breathe for the patient because they're not doing it, but because they have a pulse, you don't have to deal with compressions, right? So you just take that part of CPR out. There's some exceptions to that when we start talking about children, but for an adult, if they have a pulse, you don't have to beat on the chest. If they are not breathing, then that's what you're going to provide, or vice versa. If they are breathing at least adequately, but you get there and they've just lost their pulse, they haven't had time to lose their breathing yet. If you can start doing compressions and keep that blood flow going, they might be able to keep their respiratory drive going. That's rare. Usually doesn't work that way, but the point is that you don't have to do something if it already exists, unless it's just not adequate. So CPR steps, restore circulation by performing chest compressions to circulate the blood. So again, we do CAB. You're going to get onto your patient. You're going to do 30 compressions. At the end of the 30 compressions, we're going to open the airway using one of two methods, same as any other way. If it's not trauma related, we can do the head tilt chin lift. If it is trauma, or not even if that's the reason, but if there is suspected neck trauma, then of course we're going to do the jaw thrust. And then you're going to give them 2 breaths. Even if there's 100 of you on the scene, you're still going to, in the absence of a paramedic putting an ET tube down their throat, you're still going to do 30 compressions, then 2 breaths. All right. There's a logistical reason for this. I know that there's a lot of people out there with bad habits who just say, just do compressions and I'll breathe when I think he needs to, and they'll do them simultaneous, even without the airway. There's a problem with that though. Yes, you would think that that would work. And you guys that work at certain agencies, you've probably seen people do that. That I consider to be a bad habit. It's great for keeping their perfusion up, but the problem is it's almost impossible for the person struggling to breathe for the patient to be able to get a seal with the mask and deliver a breath that goes into the lungs and not the stomach, with somebody's head bouncing around because they're getting their chest compressions at the same time. So let the 30 compressions happen, then give your 2 breaths, then let it resume. It's just better quality. You're really not going to do any disservice to your patient by doing that. In fact, you're going to do yourself as well as the patient a favor, because if you pump a bunch of air in their stomach and suddenly you know exactly what they ate for lunch that day, it's not pretty. It'll make it to where you can't function in the back of the ambulance anymore. Not to mention all that air that went into their stomach should have been going to their lungs. So every breath you gave was a waste, and they didn't get anything. They do that on, yeah. Unfortunately, that's just the way it goes. Now, once there's an advanced airway in, yes, by all means, and they'll even tell you that in the training that you can do simultaneous. You can get somebody or like a Lucas device or something to go compressions, and it just doesn't stop. And then you give your breath every 5 to 6 seconds. But without that advanced airway in that is sealed up, and those breaths are going into the lungs, you actually run the risk of not those breaths not being delivered like they should, and then it's just a waste of time at that point. That is, if you guys can go and kind of try to break that habit. It's hard because there's people that have been doing CPR for years and years and years, and they're getting to the mindset now where um, they know better than the training, and I get it. And I think the problem is not them. The problem is the training. Is because if you guys have ever been through an actual CPR class, it is so basic and boring, and it really is built to the lowest common denominator, which for anybody in the actual medical field, it's a complete waste of your time. It feels like it, and then you tune it out. Even if you pay attention to it, it's still way below what you're capable of doing. So I think that that's where the problem is at. And I promise not to do that to y'all with this class. So you're going to give you 30 compressions. The rest of your numbers are for an adult. We're going to do at least 2 to 2.5 inches depth on the chest, and 100 to 120 beats per minute. Now, there's easy ways to remember that, but I need y'all to know those numbers, especially for your testing. All right. Um, there are some songs that we've all heard, like "Staying Alive" is in the range. So if you give your chest compressions to "Staying Alive," another one, "Bites the Dust," just don't sing that one out loud, especially if the family's there. You can use Billie Jean. "Don't You Forget About Me," that old 80s song from the Breakfast Club, if anybody knows that one. Any of those songs are a good range to just kind of play them in your head while you're giving the compressions, and you'll be in that right speed. Once you've done your compressions, we're going to do open the airway, give your two breaths, and give your breaths like somebody would actually breathe. That's another thing. So we don't breathe, inhale, inhale. That's not how it works, right? You have 10 seconds. You don't need to use all 10 seconds, but on the first of your 10-second break between compressions, give a breath. Let that inhale as you squeeze that bag take a full second. All right. So it's a slow compression. Then you're going to release and let it actually. I was hoping you wouldn't mention Baby Shark. Now it's going to be stuck in my head all night. Anyway, I'm going to try not to talk about that. Um, Once you've given a breath that lasts about a second for the inhale, yeah, appreciate that. Let them have that 4 seconds after that to breathe it out. All right, and then on the fifth second, give them another breath. So on this, by the time you reach 6 seconds, you're putting the BVM down and getting back in place to do your compressions. It only took you 6 seconds. You didn't have to use all 10, but you gave two breaths that are good quality breaths that allow them to breathe in. You know the air went where it needed to, and then you gave them actual time to breathe the carbon dioxide out of their lungs for the next breath. How do we know when the patient has gotten a good breath from us, from any device, be it a BVM, a pocket mask, mouth to mouth, any of that? How do we know that they got a good breath? Excellent. Chest rise. So we want to see equal chest rise, right? And in some trauma patients, you may not see that. If they're having a problem with a lung, that may not be equal. You get what you can get. But ultimately, we want to see chest rise. And I'll take that moment to go on this little tangent here. An adult BVM, the full capacity of the bag that we squeeze is almost twice as much as what we need to get chest rise. And half of that bag, if you squeeze all of it, all the excess is going to go into the stomach. And then you're going to get gastric distension much faster than you would if you were giving them smaller breaths. All we need to do is see the chest rise. Once you see that, you can stop. And that's especially important for children because we don't want to risk popping their lungs, right? Um, So keep that in mind. All right, it's okay to only squeeze half the bag. In fact, there are some agencies out there that they don't even carry adult bags because you could technically use a child bag on an adult. If you can't break your people squeezing the whole bag, give them a child bag. The smaller bag volume will let them squeeze the whole bag, and they can keep that habit, but not overinflate somebody's lungs. All right. So what you're seeing here is two rescuer CPR. One person is doing the breathing, and one person is doing the compressions. The only problem I see with this picture is that if you're going to maintain that seal on somebody's face, and they try to start breathing halfway through the compressions, they're gonna have a hard time with that mask stuck to their face. All right. BLS differs from ALS. ALS is advanced life support. That's what your paramedics and beyond are going to be doing. So if you're on the scene and you've got a paramedic on scene, that doesn't mean that you can stop doing what you're doing. You're still going to be the guy doing the BLS. The paramedic's going to look at you and say, keep doing CPR. That way they can focus on getting ready to shock. They can focus on doing their meds like epi and amiodarone, all the stuff that they've got to do. They can be setting the IV, putting in the advanced airway. They definitely have a long list of crap that they have to do um, on one of these calls. So when they rely on you, because even in ALS, it still starts. Everything is with the basis of good BLS. We train paramedics not to jump straight to the advanced stuff unless their BLS is taken care of. So they're going to be counting on you to do good CPR, because if they get started trying to hook up an IV and they see somebody a basic doing crap, shit CPR, they got to stop what they're doing and either coach you on how to fix it or just put somebody else in place. And if there's nobody else to do it, it's going to be them. And then if they're doing it, who's going to give the meds? So this is important. This is something that is probably the most overlooked and underestimated skill in EMS, because everybody has this concept of I do this all the time, and really they don't. If you do more than one BLS call or one CPR call a month, you actually are above average. And on a fire department, that's saying something, because there's a lot of fire departments that don't even get to the scene in time before the ambulance. So it just depends, location, population, your demographic age, where you're at, and all this plays in. Um, a lot of times, there's a lot of people out there who they may go 6 months without doing a cardiac arrest. All right, so here's your chain of survival. It's pretty much early everything. It kind of defeats the purpose if everything has to be early, but the point that it's trying to drive home is that we don't want to waste time, right? We talked about how fast they can lose brain function and things like that. The AHA does make this, the chain of survival is kind of their thing, but the faster somebody recognizes that somebody's going into cardiac arrest or at least needs help, hopefully they call 911 pretty quick. But notice here, you have high quality CPR comes before defib, and that comes before even advanced EMS. So again, it all boils down to your basics. All right, if we can get an AED on them quick, great. But don't sit there and not be doing chest compressions or something of the sort while you're waiting on the AED to come. And you can even be doing these chest compressions and CPR while somebody else is hooking the AED up for you. All right, so chain of survival, we'll skip some of these slides. It's basically early recognition, early CPR, early AED, early access to the paramedic, and then hopefully you can get them to higher levels of care from there pretty quick. This is one of those calls where if you're working in rural Poplarville, Mississippi or something, and you get this patient, you can either go 40 minutes up the road to Hattiesburg, Mississippi, or you can go 5 minutes over to what we affectionately call the Band-Aid station, um, which is it's a small community hospital in Poplarville. This would warrant going to that hospital because unless you get their pulse back, they are a highly, highly unstable patient, right? Um, that hospital should be, when you're making your transport decision, if they're unstable, they need to go to the nearest hospital to get stable, and then you can take them to a more definitive care facility from there. If they're already stable, then you can skip the first location and go to the best location, even if it's further out. But in this case, if it's cardiac arrest, even if you get ROSC back, um, it's worth the stop because they could slip back into cardiac arrest. You could at least stop there and grab one nurse or something and say, "Hey, we need you for the ride. Can you come with us just in case this patient slips back into cardiac arrest?" Um, but on the chain of survival thing, if any of this is missing, you may not get your patient back. Assessing the need for BLS, we kind of already talked about this. If you show up, the very first thing you're going to do on every call is BSI scene safety. So make sure you got your gloves on. Make sure there's nothing that's going to hurt you. Whatever it was to hurt your patient is not there to hurt you too. Figure out how many patients you have. Look around at any environmental emergencies that could be causing this, or not emergencies, but environmental issues, hazmat, these kind of things, because you want to determine based on that information if you need any help. All right, do we need the fire department? Do we need a hazmat team, more paramedics, another ambulance, that kind of thing? Um, get to your patient, and then we're going to figure out their level of consciousness. Did their AVPU? As soon as you figure out whether or not if they have any kind of consciousness to them, be it painful, verbal, or alert, then great. You can continue on with your ABCs like normal and just go from there. If they are unresponsive, then you're going to check a pulse. So don't waste time going, oh, if you hear that somebody's unresponsive in class, in the real world, whatever, don't launch into your primary um, without checking the pulse first. Because if you go 10 seconds without a pulse in that, after you determine that they're unresponsive, then you need to do compressions first, not airway first. Let's see. The basic principle is this slide just basically says that everything we've covered is about the same for adults and children and infants. There are some differences. We're going to go over some numbers differences and even some technique differences, especially when we get to the boot camp. But the idea of CPR is the same for both infants and adults. You would think that because children and infants are much more respiratory driven, in other words, most of the time that infants and children go into cardiac arrest, it's actually not their heart that caused them to do it. It's their respiratory system got shut down. You still start with compressions. It's still CAB. All right. Let's see. So this picture is just somebody that's checking responsiveness. I don't really know what he's doing with his right hand. He's a little bit low, but on the right, on his left hand, on the patient's right side, where his hand is, if anybody's ever been, I'm not going to say picked on, but I know that as kids, we figured out that pressure point on the top of the shoulders, and we used to mess with each other by pinching it. It hurts. And if they are unconscious but still able to respond to the outside world, they can still feel things. They just can't like talk or open their eyes. If you pinch that area, you should get some kind of a grimace or a recoil or something like that. And hopefully you do, because that means that they're not that far gone. But if you don't, that means they're completely unresponsive, and then you would be checking for a pulse. Okay, let's talk about AEDs for a minute. This is what you guys use as EMTs. Again, you're not going to use a manual defibrillator where you have to actually choose the electrical output. That's what the paramedics do. There's a whole nother set of protocols for that they go over in ACLS. That thankfully you guys don't have to do that. So you're going to operate these things just like anybody else in the public will. You're going to open it up, turn it on, attach your pads, and let it do its thing. And you're going to be doing CPR all through this. So this is vital in the in the chain of survival. The sooner you can get it on, the better. Because like I said, most of your cardiac arrests, they start off with electrical problems. And the AED, the quicker you can get it on there, the better. Don't forego your CPR, but don't just toss the AED to the side either. The AED should be applied to a cardiac arrest patient as soon as possible. If you witness a cardiac arrest, begin CPR and apply the AED as soon as you can get a hold of it. For children, now they had in BLS training for a little while there that if you witnessed the cardiac arrest in a child, you knew they went down right then, you could run and get help, call 911, that kind of thing. So, but if you didn't witness it, then you needed to give 5 cycles and then go do it because you didn't know how long they were down. You wanted to kind of reset or at least stop that 4 to 6 minute range problem we were talking about earlier. But now they're changing that. So first thing you're going to do is 5 cycles of CPR, then put the AED on. For children 1 month to 1 year of age, a manual defibrillator is preferred, but you're not able to use those. So what we do have is pediatric size pads or what they call a dose attenuating system. Depending on the model of the AED, that could be a key or something where you like on the unit. There's a key that you can put in it and turn it from adult to child and infant, and that actually brings down the joules that we're going to be delivering. Hopefully you've got one of those. If for whatever reason you don't, it's okay. You can actually shock an infant with adult pads. It's not fun, but you can do it, and we'll go over how to do that. There's a couple things you just have to be careful of, and they're pretty self-explanatory, but we'll cover them anyway. Some special situations. You guys have learned all these when you went through CPR, but we're going to talk about them again. pacemakers and implanted defibrillators. There's another device that we see internally in patients now that can catch your attention. Anybody tell me what those are? They assist with the mechanical flow of the blood, whereas like pacemakers are helping with the electrical impulses. Anybody ever heard of an LVAD? Okay. All right. So I don't know what y'all's level of experience is with these. I personally have only seen one. I haven't had to do any work on somebody that had it. But basically, if the electrical system of the heart is fine, but the heart is still not able to flow blood very well, say it's they've got hypertrophy or something, and the muscle's not able to do its job very well, they'll put these LVADs in, these left ventricular assistance devices, and it kind of fits over the heart like the headset I'm wearing. It looks like an operator's panel where it connects to it connects to the heart, so that as instead of the heart having to beat and push all the blood through, this thing is just a little bitty pump that flows the blood regardless of whether the heart's beating. And it's interesting because if you've ever felt the pulse of somebody that had an LVAD, they may not have one, right? Um, or it may be so weak you can barely detect it because the pulse by itself is not enough to sustain life. But they'll be sitting there talking to you just plain as day, and it's because what's happening is that LVAD is actually flowing the blood for the heart. So even though the pulse isn't enough, that LVAD's picking up the slack. But it's a steady flow, so there's no pulse per se. It's just a steady flow of blood. Um, we don't have that in the current BLS standards. I'm pretty sure that's going to show up after October 21st, though, because they're fairly new. Wet patients are an issue, mainly just standing water. If you pulled a guy out of a pool, for example, that's something you want to dry him off. But in the real world, your patient's going to be wet, even if he's nowhere near a pool, because when that blood flow stops moving, all that matrix, all that plasma starts to seep out of the patient. They get what they get that diaphoresis, which we talk about, and as fast as you wipe them off, they're going to keep leaking that fluid out. They're going to always be a little damp. So don't try to get your patient completely dry. Just get the standing water off. You don't want to have puddles on the guy or on the ground around the guy or whatever. And then transdermal medication patches. Can anybody give me an example of a medication patch that we need to be careful of? We've talked about a couple of them. All right, good. So yeah, nitro. David, I think you meant to say fentanyl. So yes, and make sure. I mean, you should already be wearing gloves, so you're not too concerned about getting it on your fingers when you first peel these things off. But be careful where you put those patches because you might go to reposition yourself and then like put your arm down on it or something. I've seen that happen where they just took off a patient's fentanyl patch, set it on the ground right next to them, and then they went to grab something out of the bag and they actually managed to somehow come in contact with that patch with bare skin. And it hit fast. I'll just say that. So be careful with that. A lot of times, if I'm going to pull a patch off of somebody, I'm just going to toss it. I'll put it in a bag, and that way it's gone because we're not. I mean, they're not going to put that patch back on. If they survive this code, most likely the hospital will put another patch on them. They'll get a fresh dose, so you don't have to try to keep up with an old patch or anything like that. Nicotine patches are another thing. Granted, I don't know if anybody would stick a nicotine patch on their upper right chest, but I mean, you never know. People put them where they can't be seen usually, so just keep an eye out for those. All right, for positioning the patient, pretty straightforward. You really can't do CPR in any position other than supine. So get the patient on their back, get them on a flat surface, a firm surface as well. If you come into let's say it's a nursing home and they got a patient that's in the bed and that's who you're going to be doing cardiac arrest or CPR on, get them to the floor. Or some places will have boards or they look like they're kind of short like KEDs, but they're kind of oval shaped, and you slide those under the patient, and you can do your compressions with that under them. Sometimes that helps. It just depends what's easier. If it's a small patient, you can lower to the ground and do that. Otherwise, slide something underneath them to give you something firm to press against, and so your patient's not just bouncing up and down on the bed while you're trying to give compressions. We do carry longboards. That is a use. That's a good use for a longboard. All right, checking for breathing and pulse. As EMTs, this is something that you will do. All right, so quickly check for breathing and a pulse. These assessments can occur simultaneously and take no longer than 10 seconds total. You can grab them either, well, in this case, you're not going to grab them by the wrist, but you can feel the carotid and you can watch them to see if they breathe. And not only can you actually do your look, listen, and feel to see if you see chest rise or any of that, but just by having your finger on their carotid, if they go to take a breath, you're going to feel it in your fingers as well. So hopefully you feel that. But that's something you can do simultaneously. That way you don't have to, waste 10 seconds looking for a pulse and then waste 10 more seconds looking to see if they're breathing. Do that together. If they don't have it, then we're going to give chest compression. So CPR, the best way I can explain it is you're going to check for something. If they don't have it, you're going to give it. Then you're going to check for something. If they don't have it, you're going to give it. Your chest compressions, we do 30 to 2. We will go over how to do that in the boot camp. You'll get to do that because one of your assessments has to be a cardiac arrest. So you're going to go through CPR and get plenty of practice with that. So I'm not going to read all this stuff. We'll get to some interesting things with this in a little bit. Let me ask you this, actually, while we're on compressions. Can anybody tell me, if I haven't already divulged this, why 30? And why do we not interrupt them? Why? It does not matter. The only thing that should stop you from doing compressions is the AED telling you that it's either analyzing or it's ready to shock. Other than that, we always get to 30, come hell or high water. If a paramedic comes up and says they're going to take over, that's fine. They can take over after you finish your 30. Why is that? That's a good answer. Calculated amount needed to make a full circle of the system, giving them time to respond because it takes that to get it back around. Okay, so I'm seeing the general consensus being, and that was a really good answer, John, that we're looking at how much it takes to circulate the blood around the system, which is going to give maximum oxygen distribution. You're absolutely right on that. There's a little bit more to it as well. So when somebody goes into cardiac arrest, what does that do to their blood pressure? And keep in mind that most of our vitals serve to maintain our blood pressure. So when our pulse, like our pulse rate and everything, um, a lot of that has to do with maintaining our blood pressure where we want it. So what happens if we go into cardiac arrest? It bottoms out, right? Your diastolic pressure is pretty much all you get. So the numbers are just going to be 70 or 60, and that's all that's going to be there. It's just the pressure of the blood in the system. Um, that's not enough to get blood to certain parts of the system, like your coronary arteries, for example. So when you start to give those compressions, every compression you give starts to bounce that systolic a little bit higher. If you make it to 12 or 15 and then you stop for whatever reason, and you only got your systolic up to like say 80, um, or you won't go with 80. 80 is actually good for perfusion. Let's say you got it up to 60, um, and then you stop. Their blood pressure is going to start to fall again from that point, which means that they may not have gotten any blood into their coronary artery. If you think about the anatomy of the heart, you've all seen a picture of it. My artistic abilities have gone way downhill since I was a teenager, so I'm not going to bother trying to draw it. But um, you have the aorta coming across the top, right? And right at the base of that, you have the coronary arteries going around the heart. They come right off the aorta. So you've got the highest pressure artery in the body going immediately to some of the lowest pressure arteries. Um, if you the valve that's there, the valve that goes off the aorta to the coronary arteries has to be very, very strong to withstand the amount of blood pressure that comes through that area with every heartbeat. Otherwise, you get all that pressure that would just blow every artery off the heart and on the first beat, and then we'd all be dead. Um, so it takes a minimum blood pressure to get blood into those coronary arteries. If you stop too soon, you may not get any blood there. So if their problem is that they're ischemic, which means that there's not enough perfusion going to the heart. If the heart is ischemic, it's oxygen starved, and you don't get any blood in the coronary arteries, all those compressions were wasted. Yeah, you might have got blood to the brain because it doesn't take much to get blood up to the head, especially when your patient's laying down. But your heart didn't get anything, so that's big. Make sure when you give your compressions, you go 2 inches because you want to give a good squeeze on the heart, and then make sure you come back up all the way. You don't want to come up so far up that you bounce your hands off of their chest, but you want to allow that full recoil so that the heart has all the room that it needs to refill with as much blood as possible for your next compression to push more blood. All right, and then before we get further, I want to go back to something that I forgot to mention with the AED. When we place patients, and this one I will draw. Give me a second to switch my displays for you. Okay. So if I've got a patient, and this is my patient, sorry, my art sucks. Where do I'm going to place my pads here. I'll go ahead and say it. I'll place my pads there and there. Can y'all see that? Why is it that this is where the pads go? Above and below the heart. Okay, absolutely. But why not place the pads here, here? John, you're on it. You want to expound on that? And you can unmute. By all means, unmute if you can. Ah, that was worth a shot. All right, so um, I'll go ahead and say it, John. I'm pretty sure you're thinking of the same thing I am. The thing about it is that your heart sits like this in your chest. All right, here's your atria. There's your ventricles. Notice that it points to the left side. Remember when we talked about the anatomy of the heart? Your SA node is right here, and then it travels basically the length of the heart. So what we do is we put the pads to where the electrical shock goes the length of the heart. If we were to place them where the X's were, then it would broadside the heart. It wouldn't really follow the right electrical pathways. It wouldn't be as good of a hit. And again, like I said, what we're doing when we do CPR or anything of the sort is we're trying to mimic normal body function as best we can. So they do make the pads dummy proof. They try to, they put the pictures on there, or I'll say army proof. Sorry to you guys. Sorry, not sorry. They put pictures on there that say, this is going to go on this part of the body. This one's going to go on this part of the body. Does it really matter if I put the chest picture on the abs and the ab picture on the chest? What happens if I get that backwards? Does anything happen if I get that backwards? Okay. So the reason that those pictures are there is because old, like back when I first got into the fire service, AEDs used to be what's called monophasic. And what that meant was that all of the shock went from pad 1 to pad 2, 100%. All right. So if you were shocking at 300 joules, you got whacked in the atria by 300 joules. Um, and at that point, yes, it did matter. It absolutely mattered, because if you reversed the pads, then you sent the shock in the wrong direction, and your ventricles would technically beat first, and we don't want that. Um, but as of about 10 to 12, 15 years ago, somewhere around in there, um, they started making AEDs biphasic, which meant that half the joules went from the first pad and half the joules went from the second pad, and they crossed. Um, the pictures are still there because people don't necessarily, especially in an emergency, the higher functions of the brain tend to actually, it's interesting how people act in an emergency, and you see it all the time. We saw it with the Station nightclub fire up in Rhode Island, where everybody went in through the front door. The club caught on fire. Everybody insisted on trying to leave through the same way they came in, because that's what we do in an emergency. We get that tunnel vision and we go the only route we know is safe. And there were other exits that could have been utilized. Windows could have been utilized that they never went out of. That's just a human behavior thing. And the same thing kind of happens when you realize that somebody might be dying in front of you. So even though these pads, they no longer matter, whether we put pad 1 at the chest and pad 1 at the abs, they kept the pictures there to help people out. Now that they're biphasic, if you get them backwards, it's okay. All right, if the chest, if pad number 1 winds up where pad number 2 is, and vice versa, that's okay. What's important is that you don't put them where the X's are. So when I'm trying to teach people, especially like teenage babysitters, people that aren't medical, people that don't handle high stress situations well for whatever reason, the easiest way for me to tell somebody to put pads on somebody is to look at your patient like you're looking at a piece of paper. We start it, if we're going to read something, we start at the top left and we end at the bottom right. So pad number 1 goes at the top left of the page. Pad number 2 goes on the bottom right of the page. And as long as you've got that, it's okay if the pictures don't match. And some AEDs now actually have a connecting strip. We'll try to just, well, I had a senior moment. Anyway, there's a connecting strip that connects the pads together in one solid piece, so that even if you put it upside down, it forces you to put them top left, bottom right. There's really no way for you to mess that up. So I know that my drawing is getting kind of cluttered, but you guys can kind of see where I'm going with that. I just wanted to show that to you. All right, let me pull back over to my slides real quick. Okay, so now continuing on. Checking for breathing and a pulse. Let's see where we left off. All right, right here. So we've already talked about the pulse. As soon as we find out that the pulse is not there, right? We've checked for 10 seconds. That's our magic number. We have not felt the pulse. We're going to immediately start to provide it, because that's what CPR is. So you're going to apply your chest compressions at least 2 inches 30 to 2, 100 to 120 beats a minute. Depending on the age of the patient, you may hear or feel some cracked bones. That's normal. Or if you hear popping, it doesn't necessarily mean that you broke bones. That could just be cartilage kind of cracking like you crack your knuckles. So that is normal. It's not necessarily that it's normal to, shatter somebody's rib cage, but if it's an elderly patient, that's pretty possible. Their bones are more brittle. That's not our goal, but it just may happen. Um, if it's a kid, they're a lot more pliable. They're more cartilage than bone. If you hear any pops on a child, it's really not bone you're breaking. It's probably their cartilage that's kind of cracking. Um, and that's fine. Usually it's just air movement. Okay, we already talked about allowing chest recoil. Proper hand position is crucial. We do this on the lower half of the breastbone. Don't go so low that you break off the xiphoid process. An easy thing is just right between the nipple line. All right, so that's just an example here of what it is that's happening when you're giving compressions. You still don't want to be off center of the chest, even though the heart sits off center. Put your palms right on the chest bone, lower half of it, and you're going to be fine. There are sometimes some complications that come out of this. So, fractured ribs, but again, if the goal is to keep them alive, bones can heal. A lacerated liver, depending on if you broke a rib and they punctured the liver, fractured sternum. Um, all of these are things that they can recover from. What they can't recover from is a heart that doesn't start back up. So don't let this stop you from giving proper compressions. Someone in the home I worked in got sued for breaking bones. Well, I mean, anybody can sue for anything. So I'm not going to say that they shouldn't have been able to sue, but they shouldn't have won. Yeah, that'd be my first question is did they lose? Like that's not something that they should have won unless there was some kind of gross negligence or something that they latched onto other than the bones because that happens. I'm not sure the guy lived because he did live. Okay. Wrong lawyer. Yeah, I was about to say, but you have the other team's lawyer on accident. No, and that happens. You may see that where you yourself get sued because I don't know, somebody in the room probably Monday morning quarterbacked you and thought they could do a better job. Like, oh my God, they broke bones. You're not supposed to break bones. You don't hear bones break in a class. I took a CPR class once and my mannequin didn't make any bone breaking sound, so that's not supposed to, it happens, but that's also ignorance, not stupidity, but ignorance on some people's parts where they just don't know. They hear bones break, they think you're doing it too hard, and they'll sue. But when it happens, um, as long as you did do what you were supposed to do and you documented properly, you should come out of that okay. You shouldn't that's not a case you should lose. All right, it's 7 o'clock. Take a break. 10 minutes after, we'll get back going. All right, let's get back on this. So we're going to talk about opening the airway and providing artificial ventilation. It might start to feel like we're kind of rushing things a little bit as we go, but it's not that. It's just that I'm going to be skipping stuff that we're really going to focus more on in the boot camp. But there is some sciencey stuff that I want to talk about in the airway and ventilation portion. So we're going to talk about that. All right. So very quickly, two ways to open the airway. Again, if there's no trauma involved, we'll use the head tilt chin lift. It's just a much better airway. Jaw thrust maneuver if we suspect neck trauma. And again, these are only good as long as you're holding them. So if you got somebody that can just do nothing but hold the airway, then great. That usually is not the case though. So once you get the airway open or established, use an adjunct that works for your patient. If you're probably going to be doing CPR, then I'm pretty sure, or I'd pretty much put money down that they'll take an OPA just fine. Um, Usually, if a gag reflex or any reflex is still there, they have to have a pulse getting blood to the cells that control that gag reflex, or or they wouldn't have it. If there's no pulse, then the gag reflex is going to be gone. If you determine that the patient is breathing adequately on his or her own, so let's say that you assess your patient, you see that they are breathing, and it's um, not just the right amount, but also good solid breaths, good depth, all that kind of stuff. Then we can roll them into the recovery position, which is typically on their left hand side. Now this is assuming that there's no trauma, say like their hip, pelvis, spine, or anything that rolling them would be detrimental to their health. But if it's medical and they're breathing good, we can just roll them over. The main reason for this is if they were to vomit, we let gravity work for us, and it keeps things from collecting in the back of their airway. So, like it says in the slide, maintains clear airway, allows vomit to drain from the mouth. If you do roll a patient, roll them as a unit. So you're going to have two or three people on the body. You're going to have one person at the head, and it does not matter who's the highest trained in this case. It doesn't matter who's been there the longest. The person at the head is the one that's in charge. All right, because they want to maintain that C spine, even if there's no trauma and suspected. We don't want to create trauma just by trying to roll their patient. So whoever's at the head, even if it's his first day on the job, he gets to be the one that says, "All right, on three, 1, 2, 3," and then y'all roll. Um, when you roll the patient, and we'll get into this when we get into trauma, just like when you're feeling a pulse, everything happens to your side. So you're going to roll the patient toward you. All right. Don't get right up against the patient and then grab on your side and try to roll the patient away. It doesn't that you it's almost self-correcting. The minute you try to do it, you're gonna be like, well, that wasn't very easy. And it just doesn't make sense. So this is the recovery position, also known as a left lateral recumbent. This particular guy is laying on no, he is laying on his left hand side. All right. So hence the name left lateral recumbent. And as you can see, he's using his hand to kind of support his neck. If um, if you need to, a lot of times what I do is I'll lift somebody's left arm up straight overhead, and then when I roll them, their head's actually sitting on their arm, and it works out even better because it props up, but it'll also allow their face to kind of angle down, and that way, if they vomit, it's just that much more coming out of their mouth, and less is going to stay in there and that they might aspirate. All right, a lack of oxygen, which is called hypoxia. Remember that? Combined with too much carbon dioxide in the blood, which is hypercarbia. Too much being hyper, and then carbia for the carbon dioxide is lethal. Um, so if you're on rescue breaths or any of that sort, make sure that you're giving good ventilation. So you have to give them enough breath that they have a good gas exchange, they get air in, and they get carbon dioxide out. Slow, deliberate, make your actual bag squeeze be a good, steady 1 second worth of a squeeze. Don't just go and expect that to be their breath. If the patient is not breathing, ventilation can be done by 1 or 2 EMS providers. I highly recommend 2 if you've got it, especially if you're using a BVM, because it's very hard to get an airway or to get it. I'm not an airway. I'm sorry. It's very hard to get a seal with one hand while you're trying to breathe with the other hand. And there's a couple techniques that we'll show you where you can use your forearm and your thigh, but even that is a pain in the ass. It just sucks. Like you do that in a pinch, but I'll be honest with you, if you only have one responder, you're much better off dropping the BVM and grabbing a one-way pocket mask and doing a form of mouth to mouth, not necessarily mouth to mouth. You're not kissing them, but this way you can still use both hands to create your seal, and you blow air into the patient's mouth. Remember, all that air in your bronchioles and your trachea is dead space. So that's what's going to go into them, and that's regular air. That's not your carbon dioxide. So it's still breathable air for them. That's actually the best. If you ever see this on a test, that barrier device, that mask, one-way valve mask, is actually the best way to give breath to somebody, because by yourself you can use both hands to create the seal. You're giving them the same kind of air. You can even hook, a lot of times you can even hook oxygen to your mask. So you're going to blow your air, which is good, plus the extra oxygen into them. And you really don't have to worry about overinflating their lungs unless you're breathing for a child. But having your face that close to them makes it much easier for you to see that chest rise as well. So as long as you're watching for it, you'll know when to stop giving that breath. All right. The thing about artificial ventilation that I want to mention, I don't think it'll say it in here. Let's see. Nope, it doesn't say it. We'll talk about stomas when we get to the boot camp. All right, so I want to say this about BVMs. We breathe, remember we talked about this in the anatomy chapter, we breathe by negative pressure, right? We're not pushing air into our lungs on a normal basis. We're creating a larger area within our chest that doesn't have enough pressure in it to equal what's pressure outside of us, so air flows in. That's a negative pressure. We're doing the opposite of that when we're breathing with a BVM, or even of any sort, whether you're blowing through a mask using the BVM, we're having to push that air in. Um, we're not meant to breathe that way, especially not for long term. So no matter how good you are about only using half the bag, or um, not overinflating and that kind of thing, you're still eventually going to reach a point where the lungs don't deflate properly. You get some gastric distension. It's going to happen, and it's going to happen because what we use is, as good as a BVM is and all that, it's still not perfect, right? The best way to breathe is by your own lungs. Um, the good thing is that a lot of times CPR in the field doesn't go long enough to see that happen. By the time we get them to a hospital, they will either probably put them on a vent or just call it. It just depends. But I want you to keep that in mind, because for every breath you give with a BVM, um, it's going to make it to where the pressure inside the chest doesn't always go back down to that base. There's going to be a little bit more pressure every single time. The worse you are with the BVM, the faster you reach that critical threshold. But even the best guy is going to still get a little bit of pressure. That's why it's like I hate seeing the new guy being thrown on airway. If I'm working the code, I'd actually rather an experienced guy be on the airway, especially if I'm a long way from a hospital, because I want somebody that's going to make that bad section, that bad point where we can't come back from it. He knows how to do it where we don't get to that point so fast. I don't immediately, 30 seconds into the call, see a basketball for a belly, because everything's going into the stomach. Ventilation is actually it's underestimated because we don't do it first, but it's very important. So you guys train on it, train heavy on it. Your new guys, I wouldn't advise putting them on airway to begin with unless you've got somebody experienced there to help coach them through as they're doing it, which, as we all know, in the real world, is almost never the case. But they do have to learn at some point. But let them learn in the classroom and get used to what they're doing and stuff like that. And there's plenty of other things that they can be doing on a scene. Let the new guy do the compressions. That way, he's definitely in the middle of the code. He's getting that experience, but he's not going to screw somebody's lungs up or make it to where their heart can't beat even if it wants to, because there's so much pressure in the lungs that the heart has no room. That can happen as well. All right, single rescue or adult CPR. For an adult, all the numbers are set in stone. There's no changing. It's 30 to 2, 100 to 120 beats a minute, 2 inches. Whether it be one rescue or two rescuers, the entire fire department, it doesn't matter. It's those numbers are always going to stay the same for an adult. So we will move on. Two rescue or adult CPR, same thing. The good thing about two rescue or adult CPR is now you can swap out, right? So we always tell people to swap out every 5 cycles of CPR, which is about 2 minutes, even if you're not tired, because once you get tired, you will stay tired, and it takes a while for you to really recover from that. Um, so the more you swap out, even if you feel fine, the more you can push that fatigue from actually getting started in the first place, the better. But again, I know that manning is an issue for people, especially in the smaller towns. A lot of times, Poplarville, for example, may only be one guy. That's all you get. And you get out into the county, like Pearl River County, you may not get anybody. It just depends because everybody out there is volunteer, and which by itself is not a problem, but volunteers have to still work. So depending on when the call happens, you just may not have anybody available. Switching rescuers during CPR is critical to maintain high quality compressions because once you start to get tired, your compressions will start to suck. And you can see it on the monitor, which we'll talk about a little bit before we end the class tonight. Some devices and techniques to assist in circulation. You have active compression to decompression CPR. This involves compressing the chest and then actively pulling it back up to its neutral position or beyond. So you can't do this with your hands. All right. Obviously, you're not going to go Kalima freaking Indiana Jones on somebody and reach into their chest. There's a device. It's like a suction cup that it almost looks like one of those electric car buffers that you use to buff the paint on your car, but it's got a big suction cup on it. So you go thump onto somebody's chest, and you can give your compressions and then pull back up on that device, and it actually pulls their chest back up. What that does is it actually, instead of allowing passive flow to push blood back into the heart, it actually sucks the blood into the heart because you're actually yanking up on it. So this may increase the amount of blood that returns to the heart and thus the amount of blood ejected from the heart during the compression phase. The impedance threshold device. This is a valve device placed between the ET tube and the bag valve mask. This can also be placed between the bag and the mask if an ET tube is not in place. And this helps limit the air entering lungs during the recoil phase between chest compressions. Okay, and no. Is that on this slide? No, it's not. Okay. Sorry, talking to myself here. So this picture on the left, that is your compression decompression device. All right, that's, like I said, it looks kind of like a car buffer. The picture on the right, you can kind of see it there. It's that yellow thing that's kind of between the BVM and the ET tube. All it does is it just seals. It seals so that when you're doing compressions, you're not sucking air into the lungs, which you would normally want that. The problem is that all that air does is because it's not an inhale. That air is just going to chill in the lungs, and then when you do go to inhale, they have less lung capacity because they've got air that's just sitting in there. Mechanical piston device. This is depresses the sternum via a compressed gas-powered or electric-powered plunge. Results in consistent delivery of compressions. This is what you see a lot on ambulances now. So they got a couple out there. Anybody have a Lucas device or heard of one? I know they have one at the base. I'm pretty sure that the ambulances themselves carry one. I don't know if Wesley's in the group tonight, but if you are, buddy, does AAA have one? You've heard of one, okay? So all these is it's just a mechanical. Yeah, I would love to have one, to be honest with you. They're pretty nice. They used to suck because they were so easy to get out of alignment, and then they wouldn't do compressions right. So the first time the ambulance hit a bump in the road, they'd be useless. But they have gotten a lot better, and they do really well. And the best thing is the machine doesn't get tired. So you can set this thing up to do your compressions for you. Not only is it not going to get tired, but it's also going to it won't lose count. It won't slow down. It will make every compression just as good as the last one, and you freed up a person to help you with some other things. So it's a fantastic device, but they are also really, really expensive, which is what sucks. You don't see them on a lot of fire departments for that reason. We have the load distributing band, or the vest CPR. So basically, it's kind of the same thing, but it's something you put it on the patient as opposed to like the Lucas device, which kind of hangs out above them. But regardless, manual chest compressions remain the standard of care because these things fail. All right. So this is an auto pulse. It's made by Zoll. It's pretty much the same as a Lucas device, but it's just a different company. Infant and child CPR. So when we talk about kids, we're talking about adults that are just smaller, right? If you're going to do chest compressions on a 10-year-old about the size of my son, um, two hands and all your upper body strength is probably going to crack every bone in his body. So I wouldn't advise that. It probably, for a child of a certain size, one hand is typically enough, and that's perfectly acceptable. When you get down into infants, now you're not even using a hand. We're using either two thumbs or two fingers. So you're just adjusting your hand placement and your force accordingly. There are some other differences when we talk about children and infants, the big thing being in the numbers. So if there's one rescuer, it's the same as an adult. It's 30 to 2. All your other numbers are the same. If there's two rescuers or more, and you actually have two active rescuers, it doesn't necessarily mean two people in the room. Just because both people know CPR, if one person is screwing around with the AED, they don't count. All right. But if you've got somebody sitting there watching you do compressions and they're waiting on their opportunity to give breaths, then you can give 15 compressions to two breaths rather than sticking to 30. The reason being is because children breathe faster than us and they rely more on their respiratory system. Not to mention, usually it's the respiratory system that messed up in the first place to cause this. Um, so more breaths is always going to be better. Which leads me to this slide. Respiratory issues are the majority of the problems with the reason why kids go into cardiac arrest. It's not necessarily that their hearts are bad. That's pretty rare. And if it is a heart issue, usually they were born with it and the parents know about it, the doctors know about it, and that kind of thing. But if a kid's just going to suddenly go into cardiac arrest, a lot of times it's a respiratory issue, and it can be from any number of things. It can be from injury, say they got hit in the chest. You actually see, like Little League Baseball, sometimes you'll find where like the pitcher gets hit with a line drive that he just threw, the batter knocks it right back at him, hits him in the chest. Sometimes that can cause these issues. Infections are huge, especially for children. Foreign bodies. I know I had a bad habit of choking on peppermints all the time. Couldn't figure out not to swallow them things whole. Submersion, electrocution, poisoning, and overdose. SIDS. Unfortunately, SIDS is a thing that we don't know what causes it. We just know that it's just the respiratory system just stops. Um, but to give CPR and everything to a child, we're going to go the same route. You're going to first of all determine their unresponsiveness. One of the differences when we do this, though, is we're not going to pinch their shoulder like we do an adult, and we're not going to do a sternum rub. The best way to determine if it's a child, like I said, a 10-year-old or something, yeah, you can pinch the shoulders and see how they react to it. If it's an infant, the best thing that I recommend to do is to flick the bottom of their foot. It's a reflex, not a pain. So if you flick their foot, or you can rub their cheek or put your finger in their hand, and if they grip your hand, all of those are reflexes. They're not active choices by the child. So if they're alert or in any way perfusing, those reflexes will be in place. If none of that works, then consider them unresponsive and go ahead and start CPR. So check for your breathing and pulse. Again, this can happen simultaneously in no more than 10 seconds. Foreign body obstruction in children is common. Like I said, I had a problem with choking on peppermints all the time. So children learn about their world by trying to eat it. If they can put their if they can get their hands on it, it's probably going to go to their mouth. And some things they can choke on. So if this is what you're dealing with, or you think you might be dealing with it, go ahead and check the child to see if they are choking on something. You might be able to see it in there or whatever. And otherwise, we're going to go into CPR. The techniques for opening the airway are the same, but with a small modification. Children, we're not going to, when we do a head tilt chin lift, we're not going to lift their head all the way back. Can anybody tell me why? Head to body size is pretty good. A little bit off target, but you're pretty warm. Anybody want to take that and run with it? Tongue will obstruct the airway. Well, that's why we do the head tilt chin lift, but there's a reason why we don't crank it all the way back for a child. So the reason, and John, you're close. The reason that we don't go all the way back, it does have to do with the fact that relative to their body size, the head is bigger. But the main issue is that their airway is still not fully formed. Their cartilage is not very strong. Um, if you crank the head too far back, the base of their skull will actually pinch the airway off from the back side of their neck. So when we open the child's airway, you're going to kind of put them into a neutral, maybe a little bit of a sniffing position where their nose is slightly elevated, but you're just not going. Ah, sorry, you were probably going to get there. Um, we don't want to pinch their airway off from the other side. So something that we do, and you guys that are on fire departments or ambulances already, you've probably seen this done. We'll take a towel, like a hand towel or something, we'll roll it up and we'll slide it under their shoulders. So we're not actually tilting their head back, we're lifting their upper body up a little bit, and then this allows their head to kind of fall back some. It puts them into a little bit of a neutral position, and that keeps their airway open. Provide rescue breathing if you can. If they don't have a pulse, oh, I'm sorry, if they do have a pulse, you're just going to breathe once every 3 to 5 seconds. Remember, children's breathing ranges are roughly 25 to 50 or 15 to 30, depending on how old they are. So we're going to breathe faster for them. If they don't have a pulse, then you're going to go to the 30 to 2. And I will add this to it because this is actually in your CPR training too. A child can have a pulse and you're still going to do compressions. If their pulse is less than 60, which means you don't feel at least one every second, they're getting compressions. That's not enough to count. All right. On an adult, if you feel a pulse, then you're good. But with a kid, it has to be faster than 1 per second. Um, Usually, if they're that far down in their pulse range, most likely it's going to be gone in a second. You may as well go ahead and start the compressions now, and hopefully get whatever's going, get it back to normal before they do go into full-blown cardiac arrest. I have found putting something under elders' shoulders, especially little old ladies, works also. Yeah, and it's also comfortable for them too. Again, the older we get, the more brittle our bones get. So you yank somebody's head back in the head tilt chin lift, you run the risk of cracking a couple of bones that way too. So you do pick some things up as you're in the field. I've seen a couple people. I don't see it's not common. I don't see people doing it for elderly very often, but it is a good idea. That's a pretty good idea. All right, interrupting CPR. We talked about this earlier, so I'm not going to harp on it again. Just remember that there's a reason. There are absolute reasons why we don't stop the compressions before we reach 30. It's because we're trying to mimic body function, and some of that requires a good bit of compressions just to get the body function back. If no ALS is available at the scene, get him in the truck and go. You can have ALS meet you halfway or at the hospital. Um, It just depends on where you're at versus where they are. But you do need to get your patient to some kind of higher care as fast as possible. So don't chill on the scene for 30 minutes doing CPR, just waiting on a paramedic to get there. If you can transport, if you have any kind of transport capability, get him in the truck and go. If you're unfortunate enough to be the fire department that doesn't transport, which most fire departments don't transport, um, then yeah, you're probably going to be doing CPR for a while. All right. So here's some rules for when not to start CPR. We are almost done, guys. We're getting pretty close. It's a short night. Some general rules regarding when not to start CPR. First of all, if the scene's unsafe. All right, that's step one in your assessment. If the scene's not safe, we don't move forward. If that means not providing CPR, then as much as that sucks, that just means not providing CPR. Think of it not just about like, I don't know, maybe a house fire next door or something like that, but think of it from your own healthy standpoint. For example, let's say it's they're down because of a hazmat scene, and there are videos on YouTube of cops getting into the, not from their own ignorance or anything. They just, like, one, he didn't see anything. The cloud was invisible. He couldn't see it. We couldn't see it in the video. He's walking up to the scene of a truck that had crashed, and he sees the driver laying out. So he's shouting at the driver, "Hey, are you okay? Hey, are you okay?" And he starts to run up to the driver. Like, he really can't see anything. He gets about halfway between his car's video and the driver, and then he just hits the ground. And he tries to keep up his radio to ask for help, and you can hear it because the video is coming from his car. Um, you can hear him trying to call for help, but all that's coming out of his mouth is just gurgling as his respiratory system just starts dumping fluid into his airway because of whatever it was in the air that he breathed in. He didn't even get to his patient to put his hands on him, and he became dead body number two. Um, it is very important. The scene's got to be safe. You're not being a punk. You're not being weak. Um, you're just making sure that you don't become the next patient, because then you got to have even more people. And the sad thing is not a minute after he hit the ground, the fire department showed up and was able to use their hose streams to push move the air, move the whatever it was that was floating around out of the way. Um, he just got there a little too quick. He was in the wrong place at the wrong time. If the patient has obvious signs of death, which include an absence of pulse and breathing, along with any of the other following findings. So just because they don't have a pulse, I mean, that's a reason to give CPR, right? But let's say you see these other things: rigor mortis, which is a stiffening of the body; dependent lividity, which is where all the blood settles, gravity just pulls it down because the heart's not beating anymore. It looks like the entire bottom half of their body is just one giant bruise. Putrefaction or decomposition of the body, evidence of a non-survivable injury. So, if the body is here and the head is over there, that's an example of a non-survivable injury. I'll say this about rigor. Rigor is not permanent. After about 24 hours, it goes away, and then the body becomes kind of limp. So keep that in mind. Look at these others as well. You may show up to a patient and you're like, well, he doesn't have rigors, and he could still be very much dead. So look for dependent lividity, look for that putrefaction or decomposition, those kind of things. There is an example of dependent lividity, and you can see where the medic or maybe the ME, I'm not really sure, they pressed on it, and you can see where it moved the blood. It's kind of like how you do your cap refill. You expect it to recover in 2 seconds is what we like, but usually it's not that fast. This obviously is not going to recover. There's no blood flow to fill that. So those fingerprints just stay there. If the patient and physician have previously agreed on a DNR, and you actually have access to that DNR, it's in date, it's got the signatures, everything is valid, then don't start CPR. But if for any other reason, if you're not sure, say somebody is screaming at you, he has a DNR, but they don't have it on them, just start CPR. You can always stop when they show you the actual paperwork, and then just document that. as you normally would. Now, when to stop CPR? So you've already started it. Um, Once you begin CPR, these are some things that can tell you to stop, and they even made a nice little acronym about it. How about that? The STOP acronym. Patient starts breathing and has a pulse, which is what we all hope, right? Which is, what is that called? I need y'all to know this term. See if anybody gets 4 letters. What is the term when a patient starts breathing and picks up their pulse again? ROSC. Good. Yep. Know that one. All right, because you're going to see that. That means return of spontaneous circulation, but they're going to always just put ROSC. Um, that's what we're aiming for. So some of your questions on the tests, especially the registry, might say, we have a patient that just achieved ROSC, and you're gonna be like, what the hell is that? That's what that is. So I need y'all to know that term. Patient is transferred to another provider of equal or higher level training. So just like any other patient, once you make that transfer, your job is done, unless like they still need your help or something. You're out of strength. So exhaustion is a reason to stop. If you just physically cannot do it anymore, then go ahead and stop. And then P is if a physician directs you to just tell you. That happens a lot. Yeah, at some point, a doctor is going to say, all right, we've been at this for 15, 20 minutes. We're going to go ahead and call it. Airway obstructions, I'm not going to bother with tonight. We're going to do the abdominal thrusts and everything when we get to the boot camp. So let me get through this, through these. All right. Special resuscitation, special resuscitation circumstances. Um, Opioid overdoses, we've talked about this before. There is something that we give. It's called naloxone, but there's other trade names for it depending on the company that makes it. You've got Narcan. It's the same thing, just different name. Um, if Narcan was administered by a bystander prior to your arrival, then determine how much of the medication was given and the route by which it was given. If a bystander did it, it was most likely intranasal. That's just the way that the general public gets Narcan. Um, a, a, you know, the layperson Walmart employee is not going to have IV injection Narcan. And even if he does, he's probably not going to have what he needs to deliver that. So keep that in mind. Also, keep in mind if the patient is in cardiac arrest, and I'm going to tell you all this as EMTs, don't give Narcan to a patient in cardiac arrest. It does absolutely nothing. It will not. It will not do anything. Once their breathing is done, or their, for what we give as EMTs, a lot of times we're going to give the intranasal as well. If they're not taking the breath, they're not going to get that into their system. Even a paramedic. Um, Everybody's first jump is to put Narcan in somebody when they think it's an overdose. But if they're already in cardiac arrest, even a paramedic trying to give it by IV, it's not going to do anything. It's just going to chill in their vein right where they put it, and it's not going anywhere. So don't worry about it. Get ROSC back first, then you can give your Narcan. And we give Narcan to stabilize breathing. We do not give it to wake them up. That's a good way for you to have a very bad day, is if you wake somebody up. Now, the only problem is obviously intranasal Narcan. We really can't control the dose that well. It's just to give it and see what happens. But your paramedics, when they give it with IV, hopefully they keep that in mind, that the goal is not to wake the patient up. In fact, let them sleep. Just make sure they're breathing. That's why we give it. Cardiac arrest in pregnancy. The priorities are to provide high quality CPR and relieve pressure off the aorta and the vena cava. This is hard to do. If a woman is in her last trimester and she's looking like she's ready to pop, if you put her directly supine, let's see, I can't tell you how many times I had a partner being and woke them up. Why? Just for that reason? Looking for a fight. That figures. Like I want to, yeah, I hate people. That's tough. Um, It's hard to do cardiac arrest calls for a pregnant person because if you put a woman supine, the weight of the baby is going to put pressure on the vena cava, and they're not going to get that good blood return to the heart, right? Because you've pinched off one of the actually you pinched off the inferior, which is where the bulk of the blood return comes from. So you give a compression and then you come up, and there's the heart's not going to be able to really refill because the baby is sitting on the vena cava. So these are a little difficult. My best recommendation is to put them on a spine board, prop them up, like kind of crank them up a little bit on their side. Usually, what I do is I like to wedge one or pick one side of the board up and put it up against the little handrail on the side of the stretcher, and then give my compressions from the side. Um, no, they're not completely on their side. That would be you wouldn't be able to give compressions that way, but just having that little bit of a rotation can take the baby weight off of the vena cava, and then you can actually get blood flow. So just something to think about, and that's something to think about. We'll talk about that again when we get to the OB and pregnancies chapter at the end of the class. If you have a pregnant woman that's having problems with her level of consciousness and everything, and she's laying flat, that's one of the things to check is she laying flat on her back? Because if so, that's usually the problem. Grief support for family members and loved ones. I have actually heard of registry questions coming from this. So this is something new. This is going into that patient affect. They're really harping now on how they want to make sure that we know how to treat people. So your patients are your customers, their family is your customers, and we are not retail, but we are customer service to an extent. So we really have to be careful how we handle the other people in the room. This is a really hard time for them, especially if you walk in and it's a kid. That's a bad day for everybody. Um, or even if it's not a kid, let's say it's, Uncle Tom who's 65 years old, or the grandfather or whatever. Family members may experience a psychological crisis that turns into a medical crisis. You may have somebody fall out in the room with you because they see you doing CPR on their husband or wife or dad or whatever. Family members and loved ones will remember this event in detail for the rest of their lives. So, make sure you document very well, especially if it's one of those complicated calls. Appropriate and supportive care at the onset of grief may positively affect the family's grieving process, and they will remember you. They will remember everything about you. They'll see you in town, and they'll remember that you were the one that worked on their grandfather. And that can either be really good memories, really thankful, like thank you for trying, even if he didn't live, or I got your number, that kind of thing. Keep the family informed throughout the resuscitation process. Designate one provider to communicate the patient status to family members. So if you can do that, if you can, and that's a good thing for the new guy. If you want to give the new guy something to do, he can be documenting everything. So we call that a scribe, right? If you've got somebody that can take notes and say, all right, at this time, we started CPR, we shocked at this time, paramedic gave a drug at this time, and what was that drug, so on and so on. And now he's got a running record of everything that's going on. So he can be watching the scene play out, documenting what happens and when, and then he can also be telling the family member, here's what we did. Where the even if he doesn't know what the medicine does, he can just say, paramedic gave this medication, we're trying to medicinally help get the patient's heart rate back, or something like that. um, that way the family is informed. They're not sitting there going, what's going on, what's happening, because that's sometimes that not knowing is one of the hardest parts. After resuscitation is stopped, these other measures can be helpful. So take the family to a quiet, private place. Introduce yourself and anybody with you. Usually we work in pairs. Um, if it's just you, if your partner is still doing something, you can pull them aside if he doesn't need you at that point, or she doesn't need you. Otherwise, you can both go. Use clear language, speak in a warm, sensitive, and caring manner. Try to exhibit calm. All right. So if you're freaking out, they will definitely freak out. Use the patient's name. Um, when when you're talking to other people. I've already mentioned in the past, if you're talking to the patient, use what they want you to use. But when you're talking to, say, the wife, use the patient's name. It helps them see that you don't see that person like a number, right? You are acknowledging the fact that this is a real person and you did your best, or you're doing your best depending on where you're at in the call, and hopefully that you get them back. While you're still on the scene, be supportive, but don't hover. All right, give them some distance, give them some room to grieve. They're not gonna be fine, even if they look fine. Ask if a friend or family member can be called to come and help support them. They may need that, but they may not be thinking about it. And then when you leave, turn the family over to someone else, for example, a police officer. Um, we all cope with death differently, but the coping is pretty substantial. So it's just like when we talk about suicide, you never want to kind of leave the person alone, right? It's the same thing here. Hand them off to somebody. You make it a warm transfer, make it to where they don't feel like you just abandoned them by leaving. You've left them with somebody else. You can continue to help them out. Ensure that children are not ignored. All right. They understand a lot more than we give them credit for. They listen a lot better than we give the credit for, and they know what's going on, even if they don't know all the details about it. So don't treat them like they're not in the room. If they're there, talk to them as well. Make sure they're okay. And the rest of these last two slides are basically just saying that your skills deteriorate. That's why we renew every 2 years. And that's going to be it. The only other thing I want to say, and it kind of goes into this last slide, and I mentioned it earlier. Um, I think everybody should be certified in CPR, some form or another, even if it's just compressions. I was doing CPR training for a bunch of the high school, not the high school, but a bunch of the school district teachers in my hometown a little while back. And I was trying to tell them, I was like, when an emergency happens, tunnel vision happens. Even to people like us who are trained in this, it's easy to get that tunnel vision in there where some of the stuff you've learned kind of goes out the window. You're like, oh my God, what do I do? Compressions. All right. If all you can remember is compressions, that's fine. So if you can get out into your community and do some community outreach, teach just the compressions. You don't have to be certified to do compressions, but if you can get that out there, and then say that you do get a cardiac arrest call in town and you're 10 minutes away, hopefully somebody on that scene knows how to do compressions, and they can at least do that until you get there. It can really benefit getting somebody back. Um, Unfortunately, from our point of view, and I get it, I do. Um, we know a lot more than the average person. So why should we be stuck watching the same DVDs that the Walmart employee and the babysitter have to watch every 2 years? That's the best way to make us complacent in our training. Um, and it's I hate that that's the way that we do it. I think that they should make training a little bit more on our level. I think if you do that and you can get people to engage a little bit better, then hey, that's that much better. Like for example, something they don't teach that I want you guys to do is throw a nasal cannula on your patient when they're in cardiac arrest. Nobody ever tells you to put oxygen on a person in cardiac arrest because they're not breathing. But what they are doing is every time you give a compression, unless you've got a device that stops this from happening, every compression you give is going to pull a little bit of air into their lungs through their nose and their mouth. So if you put a cannula on there, then even though you're not giving a breath for that 30 compression range or whatever, they're still getting a little bit of oxygen in their lungs so that when you do give breaths, you're pushing better oxygen in. Um, it also helps with cerebral perfusion when you do that. So it's not just, we tunnel vision, we even train ourselves to tunnel vision into the heart when we're doing CPR, but you got to remember the brain's not getting blood either, which is basically a stroke. So if you can do that, if you put a nasal cannula on them where their mouth and nose is still open to be able to breathe fresh air, but they get that extra oxygen, you're really going to do a lot for your patient. Um, that's the kind of stuff that they need to be teaching us, but they don't. So you guys be aggressive EMTs, be aggressive in your training. Don't take everything that I teach you and think that that's it, because there's a lot out there that goes beyond this class, even for something as basic as CPR. And with that, I will stop ranting. But let me get you your pen for the night and we'll call it. It's only 8 o'clock for y'all. It's pretty good timing. All right, tonight's will be BC 13R. All right, so tonight's pen will be B as in Bravo, C as in Charlie, BC13R. All right, R is in Romeo. BC13R. Any questions on what we covered? Like I said, I didn't want to just give you guys a 3-hour DVD and then call it a night. I wanted to do a little bit more than what that did. Is there anything that y'all have questions about? Any gee whiz stuff? Anything that you were taught in CPR and you have no idea why it is what it is? Maybe I can answer. Nothing? All good? All right. Well, with that, we'll call it a night. We'll pick back up on Tuesday. What is it? Today's Thursday. Yeah. So Tuesday, we'll pick back up with airway emergencies and go from there. We're getting into the good stuff now. This is what makes you. This is actually the EMT level stuff from here on out. We're done with the intro. So try to keep up. Don't fall too far behind on your test because it's about to get really hard to catch up if you fall behind. Y'all have a great night.